welcome to part one of two presentations on the shoulder. So the shoulder is a particularly difficult area for many people on image interpretation. So let's start. We need to have a good review of the shoulder anatomy, and then let's have a look at each of the radiographic projections and what you should see on each one. And hopefully that will help you then as we progress. So after we've done all that, we're going to look at clavicle fractures and acromioclavicular joint dislocations and subluxations. I hope you enjoy. So this slide is for you to have a quick review of the shoulder anatomy on the AP. If you wish to pause the video, feel free, otherwise just let it run. And the same again, just a quick review of the anatomy. Pause the video or let it run. These next projections are a little bit more difficult to get your head around, but just take a look at the anatomy and remind yourself where everything is, and then move on. Nice and easy, this one. Just a quick look so that you remind yourself of the anatomy, and again we're going to move on.
There are three glenohumeral ligaments, and these are comprised of the superior, the middle and the inferior glenohumeral ligament. And they provide an important role as a passive stabilizer of the joint. The long head of the biceps tendon lies within the bicipital groove, which is also called the intertubercular sulcus. The coracohumeral ligament, this is responsible for strengthening the upper part of the shoulder capsule, and it arises from the lateral border of the coracoid process, and it runs down in front of the greater tuberosity where it blends with the supraspinatus muscle. The coracoacromial ligament, this originates from the medial border of the acromion, and it inserts into the lateral border of the coracoid process. The acromioclavicular ligament, this is divided into the superior and inferior acromioclavicular ligaments, and they connect the distal clavicle with the acromion. The coracoclavicular ligament is a major vertical stabilizing factor of the acromioclavicular joint. It's comprised of the conoid ligament, which originates from the coracoid process, and it inserts into the conoid tubercle, which is located on the inferior surface of the clavicle. The trapezoid ligament originates from the coracoid process, and this inserts into the trapezoid ridge, and this too is on the inferior border of the clavicle. So let's move on now and look at the muscles of the shoulder. There are four muscles that make up the rotator cuff: the supraspinatus, the infraspinatus, teres minor and subscapularis, and this is frequently shortened to the term sits, S-I-T-S, the sits muscles. Strictly speaking, the term rotator cuff is actually inaccurate, as the supraspinatus muscle is responsible for abduction. The other three are responsible for rotation, with the infraspinatus and teres minor responsible for external rotation, and subscapularis is responsible for internal rotation. These muscles play a very important role in the stabilizing of the glenohumeral joint. Let's now have a look at the different radiographic projections. The standard trauma protocol for shoulder imaging is an AP view. AP view covers the sternoclavicular joint medially. Inferiorly, the inferior angle of the scapula and the proximal third of the diaphysis of the humerus. Laterally and superiorly are the soft tissues. The AP view allows for excellent visualization of the clavicle and the acromioclavicular joint. It's for this reason that we always do an AP view for trauma, because you don't want to have foreshortening or distortion to either the clavicle or acromioclavicular joint. The humerus should be held in external rotation so that the greater tuberosity is seen in profile. Always ensure that the arm is relaxed down, because when patients are in pain, they tend to elevate their humerus, which creates the appearance of loss to the subacromial space. The scapula sits obliquely to the chest wall, and so that on an AP view, the surface of the glenoid is tilted between 35 to 40 degrees anteriorly. And we need to understand the overlapping structures of the head of humerus. So on the AP view, we can see both the posterior rim of the glenoid and the anterior rim of the glenoid. The medial border of the head of humerus must overlie the posterior border of the glenoid. But importantly, the medial border of the head of humerus does not overlie the anterior border of the glenoid. Finally, always remember to check your lung fields, look at your ribs to make sure you haven't missed any rib fractures or a pneumothorax or even a tumour. To reiterate, I want to emphasise how important it is to understand the appearance of the head of humerus in relationship to the glenoid on the AP view. It's important that you learn this because this will assist with diagnosis for dislocations, which we will discuss later on in the presentation. So, to reiterate, the medial border of the head of humerus, which is demonstrated as the green line, must overlie the posterior border of the glenoid, which is demonstrated as a dotted red line. However, the medial border of the head of humerus must not overlie the anterior border of the glenoid, which is demonstrated in yellow. The Grashey view provides excellent visualization of the glenohumeral joint, and it's for this particular reason that any patients who have a manipulation to reduce a dislocation, when they return to the X-ray department, their follow-up images should include a Grashey view rather than an AP view. The reason being that we no longer need to assess the clavicle, the acromioclavicular joint or the body of the scapula. That's already been performed on the initial imaging. If you remember, on the AP view, the glenoid surface is rotated anteriorly between 35 to 40 degrees, and it's this obliquity to the glenoid that makes it very difficult to assess for any fractures, specifically to the inferior margin of the glenoid. So to perform a Grashey view, you rotate the patient 35 to 40 degrees so that the glenohumeral joint is perpendicular to the receptor. An excellent Grashey view will have complete superimposition of the anterior and posterior margins of the glenoid. And what you're looking for is that the medial border of the head of humerus demonstrated here as the red line, should not overlap the superimposed borders of the glenoid, which is seen over here in yellow. The joint space between the glenohumeral joint should be between 0 to 6 millimeters. The arm should be externally rotated again so that the head of humerus is demonstrated in profile. Okay, so let's move on. The lateral or Y view is not very good at assessing the glenohumeral articulation. However, it is good at assessing the diaphysis of the humerus, as well as the body of the scapula. It's called the Y view after the appearance of the scapula is similar to that of a Y, with the spine of the scapula forming one strut of the Y, the acromion forming the second strut of the Y, and the body of the scapula forming the third strut of the Y. A well-positioned Y view will have the glenoid, which is demonstrated as a dotted red line, over the centre of the Y, and the head of humerus, the dotted yellow line, superimposed over that. The Y view is vulnerable to poor positioning, and also if a patient is very kyphotic, what will happen is the ribs will be projected over the glenohumeral joint, making it difficult to evaluate this area. The axial view provides excellent visualization of the glenohumeral articulation. The problem with this view is that some people find it difficult to identify the bony landmarks. I think what I find easiest is if I can identify the clavicle, because I know that my clavicle lies anteriorly. I also know that my clavicle articulates with the acromion to form the acromioclavicular joint. So if I know that this is my clavicle and this is my acromion, this must mean that this must be my coracoid process. Hopefully that will help you now to identify the correct bony landmarks. The other problem with this view is that it can be very painful for the patient to put themselves into the correct position. So we'll now discuss the half axial view. The half axial view makes for an excellent alternative to the axial view, particularly for patients who are in a lot of pain, as the positioning for the half axial view creates no further discomfort. The excellent book Accident and Emergency Radiology used this picture to demonstrate the positioning for the half axial view. Unfortunately, it's frequently misinterpreted. The actual positioning for the half axial is like the Grashey view, so that the patient is rotated between 35 to 40 degrees, so that the glenohumeral joint is perpendicular with the detector. At that point, the central ray is then angled 45 degrees caudally to the glenohumeral joint. So, positioning for half axial is the Grashey view, and then with a central ray angled caudally 45 degrees. So, anatomy. The clavicle is anterior, which meets with the acromioclavicular joint, and therefore this protrusion of bone is your coracoid process. As we can see, we have excellent visualization of the glenoid to assess for any fractures, and the head of humerus articulates with the glenoid. Injuries to the shoulder joint are common throughout life. However, the type of injury is dependent on age. Clavicle fractures can occur from birth trauma, particularly if the baby is breech or very large. During childhood, Injuries tend to occur at either the clavicle or the proximal humerus, and these usually occur because of play or sporting injury. Adults between 20 to 45 years of age are more likely to sustain a glenohumeral or an acromioclavicular joint dislocation. These are normally caused from a direct fall, sporting injury, or a fall onto outstretched hand. Once patients reach over the age of 45 years, they're more likely to sustain a fracture to the proximal humerus, and that's usually due to a fall on outstretched hand. These particular injuries tend to occur in osteoporotic women and are similar to those of a Colles fracture or a neck of femur fracture. Throughout life, mid-diaphyseal fractures can occur from high energy trauma. Clavicle fractures are found in 5 to 10% of all shoulder injuries. Of these, over 50% are seen in children under the age of 10. Now, what I really want you to remember is that 80% affect the middle third, and this tends to occur where the diaphysis of the clavicle overlaps the ribs. So it's very easy to miss an undisplaced clavicle fracture, so check that area particularly carefully. The lateral third are responsible for 10 to 15% of fracture locations, whereas the medial third only is responsible for 5 to 8% of fractures in this area. Here we have a fracture of the mid-diaphysis of the clavicle. These types of fracture tend to occur with superior tenting of the fracture site. The reason being is that the medial portion is elevated by the sternocleidomastoid muscle, whereas the lateral portion is depressed by the weight of the shoulder and upper limb. When we look at these fractures, it's particularly important to check to see if you can see any rib fractures and to look to see if you have a pneumothorax. Frequent in paediatrics, this particular fracture site tends to be undisplaced and will overlie the rib, so be very careful to check to make sure you haven't missed a fracture there. We can see that our acromioclavicular joint is preserved, as is the coracoclavicular distance. So, what is it? It's a fracture. Where is it? Mid-diaphysis left clavicle. How? Superior tenting. Comminution and overriding of the fracture fragments in clavicular fractures is very common. So what do I mean by that? Well, comminution means there are multiple fracture fragments, and overriding is where two fragments are shortened in relation to one another due to overlapping of the proximal and distal fragments. So classically, in clavicular fractures, the distal fragment here underrides the proximal fragment. And remember, the proximal fragment is elevated due to the sternocleidomastoid muscles, whereas the distal fragment is depressed due to the weight of the shoulder and upper limb. So, what is it? It's a fracture. Where is it? It's the mid-diaphysis of the right clavicle. How? Comminuted, displaced and overriding. It's important to understand what a normal acromioclavicular joint is so that you can recognise an abnormal joint. A normal ACJ ranges between 3 to 5 millimetres. However, it may be as much as 7 millimetres in some cases. The difference between two sides should never be more than 2 millimetres. However, these days we no longer do comparison views, so unfortunately this isn't very helpful. The acromioclavicular joint is a synovial plane joint, and as with all synovial joints, as we get older, they're vulnerable to joint space reduction. So often, in patients over the age of 60 years, the joint space may be less than 2 millimetres. Finally, when you're assessing the acromioclavicular joint, always assess your coracoclavicular distance. And this distance is usually between 11 millimetres to 13 millimetres. Rockwood identified 6 types of acromioclavicular joint injuries. Type 1 involves a sprain to the acromioclavicular ligament. Because it's only sprained, there is a normal acromioclavicular joint, and therefore the X-ray is normal. Type 2 involves disruption to the acromioclavicular ligament and a sprain to the coracoclavicular ligaments. Therefore, the coracoclavicular distance is normal, but there is superior subluxation of the acromioclavicular joint. Type 3 involves disruption to both the acromioclavicular and the coracoclavicular ligaments. Because both ligaments have been disrupted, there is now superior dislocation of the acromioclavicular joint. Type 4 involves disruption to both the acromioclavicular and the coracoclavicular ligaments. However, the clavicle is dislocated posteriorly, and although it may appear as superiorly subluxated, it may also appear normal on the X-ray. Therefore, type 4 is a clinical diagnosis rather than a radiological diagnosis. Type 5 involves a disruption to both the acromioclavicular and the coracoclavicular ligaments, with gross displacement of the clavicle. Type 6 also involves disruption to the acromioclavicular and the coracoclavicular ligaments. However, the clavicle is displaced inferiorly to the coracoid process. The acromioclavicular joint should always be assessed on an AP view. It's important to understand that because of the Grashey view leads to foreshortening of the clavicle, this can actually create a misleading impression of subluxation to the acromioclavicular joint when it's just a projection. So how do we assess the acromioclavicular joint? We need to assess the inferior border of the clavicle in relation to the inferior border of the acromion. This should be completely in alignment. It's important not to use the superior border, as sometimes the clavicle can appear quite bulbous, giving a misleading impression of being superior subluxated in relation to the acromion. So let's have a look at this a bit more closely. On this radiograph, we can see there has been a superior subluxation of the acromioclavicular joint. Remember, when we assess the acromioclavicular joint, the inferior border of the acromion and the inferior border of the clavicle should be in alignment. Here we can see that there has now been superior displacement of the clavicle in relation to the acromion. Because the clavicle still has partial communication with the acromion, it's a subluxation rather than a dislocation. Remember, a joint is either subluxated or there is a joint subluxation. The word subluxed is incorrect and shouldn't be used. When we look at this image, we should always consider the coracoclavicular ligament, and this distance between the coracoid process and the conoid tubercle should measure between 11 millimeters and 13 millimeters. This coracoclavicular distance has been preserved, and therefore we know that if this has been preserved and there has only been a subluxation to the acromioclavicular joint, this must be a type 2 acromioclavicular injury. So, what is it? It's a subluxation. Where? The right ACJ. How? Superior. Here we have an acromioclavicular dislocation. So, remember, to assess the acromioclavicular joint, we look at the inferior border of the acromion and the inferior border of the clavicle. These should form a nice, smooth, contiguous line. However, we now have superior dislocation of the clavicle. The clavicle does not communicate at all with the acromion, and therefore it is a dislocation and not a subluxation. Let's look at our coracoclavicular distance. Our coracoclavicular distance should be between 11 mm and 13 mm. There's diastasis of the coracoclavicular distance, and therefore we know that both the coracoclavicular ligaments and the acromioclavicular ligaments are disrupted. Therefore, this is a type 3 acromioclavicular injury. So, what is it? It's dislocated. Where is it? The right ACJ. How? Superior. That marks the end of part 1, and I'll see you again for part 2.